Okay, I think we can go ahead and get started this afternoon or morning, depending on where you are in which time zone while you're looking on today. Welcome. My name is Joseph Gahn. I'm a professor here of anthropology and of global health and social medicine at Harvard University. And I'm really pleased to welcome you to this seminar today. This is the first seminar for our annual departmental seminar series for the Department of Global Health and Social Medicine at Harvard Medical School. This is the first one for this academic year. Just so you know, these will generally be held at 2:30 p.m. on the first Wednesdays of the month looking forward. Today's seminar is a little bit special because it is part of what we call the Indigenous Health and Wellbeing Colloquium series, which I am pleased to host. This is a co-sponsorship between the Harvard University Native American Program, for which I serve as faculty director, as well as Department of Global Health and Social Medicine today. So let me start with an acknowledgement of land and people, as is often our custom here in academia. Harvard University is located on the traditional and ancestral land of the Massachusetts, the original inhabitants of what is now known as Boston and Cambridge. We pay respect to the people of the Massachusetts tribe, past and present, and honor the land itself, which remains sacred to the Massachusetts people. I'm about to introduce our speaker for today, but before I do, let me just explain that on this webinar, questions and answers will be handled through the Q&A function. Should be a button at the bottom of your Zoom screen. So if you have questions that arise over the course of today's presentation, please enter your questions right in there. And then when Dr. LaFromboise is done presenting, we'll shift into a time where we'll take her responses to some of these questions that you contribute. So I hope that's clear. Let me start today then by introducing our speaker, Teresa LaFromboise. Dr. LaFromboise is a counseling psychologist and a tenured full professor in developmental and psychological sciences in the Graduate School of Education at Stanford University. Her research focuses upon efforts of non-dominant racial ethnic groups to thrive despite adversity, including discrimination, acculturation demands, and major life challenges. She has extensive experience developing and evaluating school and community-based psychological interventions with American Indian, Alaska Native adolescents, as exemplified in the American Indian Life Skills Development Curriculum. In addition to serving as the director of the Native American Studies program within the Center for the Comparative Study of Race and Ethnicity at Stanford, she contributes to the Child Health Research Institute at the Stanford School of Medicine. Teresa is currently writing manuscripts on findings from a community-initiated study of cultural revitalization, psychological well-being, and academic engagement among tribal college students. Within the American Psychological Association, she's a fellow of Division 17 and 35, and past president of the Society for the Psychological Study of Culture, Ethnicity, and Race, which is Division 45. She also served as a member of the APA Committee on Rural Health. LaFromboise is a fellow of the Association for Psychological Science and a past president of the Society of Indian Psychologists. We're so delighted to have you today for our first seminar, Teresa, and the title of your talk is The Potential for Schools as Sacred Spaces in American Indian Alaska Native Adolescent Suicide Prevention. So let me turn the floor over to you, and we're excited to hear what you have to say. Thank you for joining us.
Great. Thank you, Joe. Appreciate it. Let me just see if I can get this presentation up. Oh, very good. Okay. All right, very good. Thank you. Well, let me begin by expressing acknowledgement for the people whose land that I'm honored to be able to live on. I'm in the spirit of healing. I recognize that we live and work on the ancestral land of the Muwekma Ohlone people. I acknowledge and honor this history, as well as recognize the ongoing importance of Indigenous culture to the land and the communities in which I live, learn, and serve. And thank you, Joe, for inviting me to be a part of this seminar series on Indigenous health and well-being. So just to begin, I realize that this is an emphasis on upstream and positivity and well-being, but I do think we need to set a little bit of a context. American Indian Alaska Native individuals are more likely to think about, attempt, and die by suicide than any other racial or ethnic group. beginning at about the age 5 until approximately age 45. Suicide is the second leading cause of death among Native 1 to 19-year-olds in that grouping, and then it is also the second cause of death within the 20 to 44-year-old age group. What's unique, I think, about this figure is that it very vividly shows that suicide is extremely high in the 15 to 25-year-old age range, and that it gradually begins to taper off in around the 30s on down. And you can see the difference very much between the Native American group, the line versus the non-Hispanic white, and then the lines below are non-Hispanic Black, non-Hispanic Asian, and Hispanic, but clearly distinctly different. Suicide rates have increased among Native people. This is the beginning. This is reported by the CDC, and starting at in 1999, but you can see the steady increase up to 2017. I'm going to carry it on out in some subsequent slides. But again, it is, steadily increasing as with other groups, but more so in recent years. This slide looks slightly different because it's at this point, the CDC is reporting out and separating out Asian from Pacific Islanders, but still, again, the top line is Native American, American Indian Alaskan Natives. In 2018, the rate of suicide per 100,000 population among American Indian Alaskan Natives ages 10 to 24 was 29.4. as compared to the overall rate of 11.6 in that age range within the general population. The Youth Behavior Risk Survey reports in 2021 that an estimated 14 to 27% of Native American adolescents have attempted suicide. This is showing again, the increase among the older group, the 25 to 44 years, but still very high and increasing rapidly. I think the important part when you show population slides like this is the fact that we do recognize they're very limited in that there's so much heterogeneity among Native nations. It's a very different rates among them. But unfortunately, we can't talk very much about that because we do not have the suicide rates for every one of the 574 tribes, nor very much data on Native people who live in urban and other non-reservation areas. When we get into possible reasons for this, there are so many, but I do appreciate the way that Lawrence Kermeyer has mentioned this from more of a community perspective, and I just want to go over those. I think we could say reasonably that intergenerational trauma, cultural discontinuity, community struggles such as poverty, insufficient, inadequate housing, low education, employment issues, and lateral violence, and then familial factors from historical and ongoing trauma. This one lists poor parenting. I'd rather say challenged parenting, substance use, mental health challenges, etc. However, so we do know that Native American youth experience many of the same developmental stressors that other youth do, but then there are these unique aspects as well. And that helps us then try to tackle the issue of the disproportionate number of Native youth attempting and dying by suicide, and hopefully we'll suggest some ways in which we can intervene. I'm a little bit on a mission at this point in time to try to emphasize the fact that schools are a very critical context for suicide prevention. I was part of a group that presented a grand rounds to the CDC on the issue of place in suicide prevention a few years ago. I talked about schools, someone else talked about work as a place, and then also Spiro Manson talked about medical settings. So I'm just going to go over the part that I tried to emphasize about schools. And I have to say, part of the reason I really feel strongly about this is I used to teach 7th and 8th grade in high school before I became an academic. And I really do enjoy doing research and also consulting with schools. It was really fun to be in some back to school nights this fall and work with some students at Stanford that are doing some studies in the schools in the Northern California. Schools are second to families in their potential to affect children's mental health. They are the de facto mental health centers for many children. Schools provide important access to prevention services. That's why I have this little girl with her baby. If those of you can remember the teen pregnancy prevention interventions a few years ago where they carried around baby dolls to get a sense of that. But anyway, they provide daily opportunities for educators and other professionals to connect with children and families and to identify problems and to offer support. There have been suicide prevention, school-based suicide prevention schools since 1984, to my knowledge. They began as a result of an escalating trend in suicidal behavior among adolescents in Western industrialized nations. The rationale for schools adopting suicide prevention hinges on recognition that a significant amount of suicidal behavior occurs among ostensibly well-functioning students. I believe that schools can become sacred spaces because transcendence happens when learning happens, transcendence occurs. And I've been in a number of tribal schools where I really did believe that they were very sacred places. Some examples of, and I think that's increasing as more and more tribal leaders are developing their own schools according, to their ideas of what is education, what learning should occur. A few that I've appreciated is seeing students come into the school and at the very beginning an open convocation outside generally, but of a welcoming song before they went before they began classes. In South Dakota, Gene Thinelk and Dwayne Mackey had an intervention called the Heart Room, where there was a space within schools where children could go on Fridays for prayer and thought with elders around the upcoming weekend, and then they would return back to the Heart Room on Mondays to kind of think about where they were going to be getting situated back into the school environment. It was a really beautiful program. It was hard to have many schools open up the space for that, but it was a beautiful experience. Of course, we know about how often schools are used for community functions, and for many of those they are ceremonies. So I just want to bring that home, that I think that they can be sacred places. Just recent research this last year by Mann and Walsh found that in 2 different studies that students feeling connected with a parent or a non-parental adult and a positive school environment is a great protection against non-suicidal self-injury, suicidal ideation, and suicidal attempts. So just trying to get a little bit of energy going here on the idea of school. One of my students felt that I needed energy in my slides. For the longest time, I've talked about how I felt like there wasn't enough attention to schools, and thankfully, last March, a year ago, in March of 2022, as a follow-up to some states advocating for mental health education and suicide prevention training in schools, the Stand Up Act was passed unanimously by the Congress, and it was in March in 2022. Stand Up stands for Suicide Training and Awareness Nationally Delivered for Universal Prevention. Basically, this was an act that encourages federal funding or provides federal funding for mental health and suicide prevention programs, and encourages states and tribes to implement and expand evidence-based suicide prevention training in schools directly to students through in grades 6 through 12. Recent research has found that students who receive a student focus suicide prevention, and I want to emphasize that a lot, because sometimes schools just really think, well, if we can, should we just train teachers and staff? But we are finding now that it's very important for it to be student focused. That those that do have that kind of programming, there's a 13 to 15% lower odds of suicidal ideation, and 28 to 34% lower odds of suicide attempts. This is an experience that I've had that I still deeply appreciate, and that is to be able to develop an intervention, a suicide prevention intervention for the Pueblo of Zuni. In 1989, suicide was a very sensitive topic and concern among the Pueblo of Zuni, because 5 high school students had died by suicide in 1 year. And the community at that time, the population on the reservation was 7,000. They were very, very obviously concerned about this, and they did not want someone coming in from outside, and actually spent about a year in conversations among themselves trying to figure out what to do. And at the time, I was a member of a committee called the Zuni Stanford Committee, and it was a committee of Stanford faculty and Zuni community members selected. This faculty were selected by their ability to respond to the requests of Zuni. These were not faculty-initiated activities. We were responding to requests of Zuni. And the superintendent of Zuni Public Schools asked me what I knew about suicide prevention. I had volunteered on the suicide prevention line during doctoral training, and I had just finished and published an article with Dolores Bigfoot on cultural and cognitive considerations for Native American adolescent suicide. I said, that's what I've done. And he said, well, if you're welcome to consider it if you want to come out and we can talk about it, which I did with some students from from Stanford. And basically, over a period of 3 years, we developed a curriculum. The first year we spent a year developing it. Second year we pilot tested the curriculum, and the third year we did the final evaluation. I think using the terminology that's used today, this was definitely a community-driven initiative. It is a universal suicide prevention effort because we felt that we wanted all students engaged in it. It is culturally grounded, and it engages the teachers and staff and students. And then later on, we were able to engage parents in fostering social responsibility and social emotional learning as the curriculum evolved. This is a logic model that we created after we developed it, because we need logic models and proposals and things like that. But I think it explains what we're trying to do. On the left column, where you see risk factors, I've outlined some, and I've tried to divide them into individual, social, and ecological risk factors. Most of you are familiar with the individual and social risk factors, but I'd like to explain a little bit the ecological risk factors, kind of like what's in the air, what's always present. And it seems to me that historical trauma and then acculturation pressures and unfortunately too much poverty for many, many generations seems to be there, ever present. But anyway, we have these risk factors. Students are exposed to some of those. Generally, the more that risk factors, the more difficult it is. But according to the stress coping perspective, there are risk factors, and then a stressful event occurs. And of course, this is simplified just for ease in designing. people generally either seize the day and try to deal with it, or they avoid coping in order to handle the situation. And one of the reasons I selected this is because over the years and in the work that I've done, I've seen more and more, it seems to be the pattern, that when students are having a multitude of problems, they may tend to overlook them or forget it, try to stay away from them, or just avoid the situation in terms of trying to handle them. And so breaking it down simply, they don't get involved so much in problem solving, and often a lot of negative thinking occurs, which could lead to suicide. The with the advent of many interventions, not just American Indian life skills, sources of strength and other interventions are really trying to, I think, increase the adaptive resources of students, and are teaching more, emphasizing approach coping. But certainly we were in this curriculum. We were trying to help people understand themselves better, being able to identify and monitor their emotional arousal, learn how to discuss problems with others, begin to take direct action, and seek social support. So we're trying to increase coping. And of course, in the curriculum, I'll just move on here. You see these two: effective problem solving. We're assuming over and over again. This is emphasized in many of the skills areas of the curriculum, which I'll show in the next slide, that through repetition of these mediators, that people will be resilient. Okay, so what you see here are the skills of the curriculum. It's a heavy dose of skill training, but the curriculum itself is saturated with constant positive health messages and emphasizing protective factors, such as being able to discuss problems with family, and feeling in control, and learning emotional health, learning how to control feelings, and being in mindfulness, and also connectedness to family. But if you can think of it from a curricular perspective, we teach these different skills: depression recognition and management, stress management, anger regulation, and then we have a conventional crisis intervention, suicide prevention, and then community and personal goal setting, so that it isn't all culminating with learning suicide prevention. But each one of these lessons within those sections and skills really emphasize positive thinking and effective problem solving. So even though we're doing anger regulation, the lesson helps people learn how to regulate their anger by thinking positively and thinking about other things while they're calming down, and certainly about how to solve problems in order to avoid escalation to anger, etc. So over and over again, the constant reminder are these positive thinking and problem solving. AILS is widely used in schools now, all types of schools with Native American students, Bureau of Indian Education schools, tribal schools, charter schools, alternative schools serving Native students in urban areas, and also Indian education programs in urban areas, or in areas that have large number of Native students. And that is often done through the Indian Ed program or weekend kinds of opportunities. The outcome goals of AILS are to change suicidal thoughts and behavior, to increase help seeking, to increase suicide knowledge and awareness, and to increase the awareness of local resources for mental health and suicide prevention. So these are the sections of the curriculum. There are 44 lessons in the curriculum, and some lessons take more than one class session. We did this, and this was before the evidence-based intervention movement and really tight protocols for interventionists. But, recognize I'm an educator. The people I worked with were educators, and we wanted to, teachers like academic freedom, and therefore we gave them many opportunities. So within the first section on building self-esteem, there are 7 lessons, and we wouldn't expect that a teacher would need to do all 7 lessons, but those are the options, and we're encouraging the interventionist or the teacher to use as many as he or she feels are needed to get the comfort in the classroom with this kind of work, and building some trust and learning the norms of being able to do social emotional learning kind of work. Second, one of my feelings, emphasis on identifying emotions, being able to talk about them, identifying stress, being able to manage stress. Then we move into communication skills, open communication, iMessages, that kind of thing, and then ways to solve problems. And again, that's very much a social cognitive solving problem solving model. This section 4, we added between the pilot implementation and the final evaluation in between years 2 and 3, because when we piloted it, a lot of the students were saying, well, what's wrong with this? Why are we so suicidal? And so we felt that it was very important that students realize that there's a background to some of this anger. There's a history, and that it's reasonable that some people would have strong feelings about what's happened historically, and then also work on what is a what is the dysfunctional family? How do I handle what is risk behavior? And it starts small, not wearing seat belts, not wearing helmets, dabbling with smoking, these different kinds of things, and it moves on to more end-stage behavior. Just some of that background that they seem to need at the time, so that we added those lessons. And then we move into sections 5 and 6, which are sort of very important information about, knowledge about suicide, and then learning. The capstone is learning a 4-step plan in which they learn how to identify their feelings, what is the problem, what are possible resources that I could go to within the community, what's available at school, who are people within my family I trust, who are those trusted adults, and then then the action step is going to see that person and actually getting help. And then we wanted it to end positively, so we have this section on planning ahead for a great future. We asked students to envision their community in 100 years. We have a lesson like that. We have many different lessons they're kind of standalone lessons. They're great lessons for people that are interested in career development and that kind of thing, but it's working towards the future. And that way that we're not just bringing them up to, learning about suicide and then the intervention is over. Okay, so I'd like to just go over briefly three studies. I'll try to be as brief as possible that I think support the effectiveness of Zuni life skills. And I must say that after this evaluation, the curriculum was then published, and with the permission of Zuni, it was renamed American Indian Life Skills. But this is the first study, and this was done at Zuni. This is in year 3 after we've piloted it for a year. The curriculum was implemented 3 days a week, Tuesday, Wednesday, Thursday, in freshman language arts class. 128 students participated in this. 101 were freshmen, and then we also included 27 junior students. And the reason we included that is, of course, we needed the sample size, but we were also offering a refresher in the junior year. So we thought we could see how junior students responded to the curriculum. 65% were girls, 35% boys, ages 14 to 19. When we first began this work at baseline of this evaluation, 81% of the students were in the moderate to severe range on suicidal ideation at pretest. 40% of the participants had a relative or friend who had died by suicide. and 18% of the participants reported that they themselves had attempted suicide. And in the way we worded the question, it was clear that we weren't talking about just thinking about doing something. It was actually that they had done something physically to attempt suicide. So after we implemented this, it's a very high dosage. It's not all 44 lessons, but it was offered 3 days a week for the course of a year, academic year. We found that the differences between the intervention group and the comparison group, the intervention group were significantly less hopeless. They had greater confidence in their ability to manage anger as well. And then we had also, that's in the student self-report. Then we were able to do a behavioral role play. We select randomly, and by that time we could randomly select. At the time we designed the study, they wouldn't allow us to randomize, but by the time we were now at post-test, and we were only using a small number of the students, we randomly selected out a third of the students from the intervention group and a third from the comparison group. And we put them through 4 role plays. 2 were general problem solving situations, and 2 were suicidal situations. 1, an indirect implication of suicide. The other was much more planned. And I have to say that none of the Zuni students role played being a suicidal person. We basically presented the Confederate client, and the Confederate client were 2 Native students who were working with me at the university, and we brought them out to Zuni, and they role played, and they were not, their tribes did not have this kind of prohibition against talking about suicide, and so they role played the suicidal youth, and then the Zuni students and participants in our behavioral studies help them using suicide prevention skills. And then we had trained raters who were Native American, and they found significant differences between the intervention and comparison group in their suicide intervention skills and their general problem solving skills. This study is an independent evaluation. It was conducted in New Mexico in another community, and basically I had conducted ALS training with the educators and behavioral health specialists in that area, and they had a grant for substance abuse prevention, and so they were able to have their evaluators also evaluate a very small dosage of American Indian life skills. And when they were planning it, they asked me, they said, Teresa, we can't do this whole curriculum. We are only going to have 10 lessons in the high schools with students, and what would you recommend? So I recommended, I actually couldn't narrow it down to 10. I recommended 13, and then they selected 10 of them. And they were able to work with 90 high school students. I mean, basically they evaluated 90 high school students across 5 schools. 40% were males, 60% females, again, 14 to 18 year age range, to get a sense of the traditionality, I guess you could say, of the community. 50% of the students spoke their language at home other than English on a regular basis, and 50% did not, but half of them did. And so this is only a pre-test, post-test. There was not a comparison group. That is a weakness of the study, but nonetheless, this is the study that they did. And so it's pre-post, and there was a decrease in hopelessness and suicidal risk, and also an increase in public collective esteem, which is an aspect of racial identity. What do I think? What does the participant think that other people think about their racial group? And then self-efficacy and self-awareness. over time, it became really clear, and actually at the time we were asked to design the curriculum at Zuni, I had really hoped that we could develop a middle school version, but they wanted it to be at the high school level. So it seemed important that we do a middle school version, given the staggering rates of suicide among even younger Native early adolescents. So we have adjusted the content at an early adolescent developmental level. We've simplified the capstone experience. We reduced the dosage to 35-minute lessons because at this point we do not have the freedom to choose among a number of lessons, however often we want. So we're adding more structure to it. So the intervention is 35-minute lessons. And we learned from some of our preliminary work that students, and doing a comparison with another evidence-based intervention, Reconnecting Youth, that students really love workbooks. So we also developed a workbook. So this study is a study of that middle school version, where I was able to come back to Zuni 18 years later to work with them on a middle school evaluation. And actually the work was funded by a grant from the that was secured by the superintendent of Zuni, no, by the Institute for American Indian Arts, but it was, then funneled to Zuni to do this work. So 141 Zuni middle school students were randomized. We could randomize now, okay, to receive the curriculum. We did this over the summer with the with the school counselor to randomize the students into social studies classes, so they were already randomized. And so within the social studies classes, some received the curriculum, some did not. We pre-tested everyone at the beginning of the year and began the first group. So it lasted for 6 weeks, which I think is too intensive a dosage, but that's what we were allowed to do. And then the second group began at the end of that time for another 6 weeks. And what we compared in the evaluation was on the post-test of the first group with the pre-test of the second group. And we did we did measure depression, suicidal ideation, hopelessness, and then the efficacy around the ability to do the skills in the curriculum. And this is this is showing you the results of the difference between pre-test and post-test of the second group on efficacy items. And the reason for that is that we had not refined our efficacy scale when we, we're lucky to get the grant at the time of the pretest. So it sounds a little messy, but this is definitely an example of the evaluation in which the rigor with which we're wanting to present any results on the evaluation. So this is pre-test, post-test on the second group, and we found significant differences between pre and post on the students' confidence to manage depression, cope with stress, enlist community support, and enlist social resources. We didn't have, I will say, we were also testing out some aspects of the curriculum. We did not, in this evaluation, we utilized external facilitators. One was a community member who was very well respected. She had a master's in public health, and she was able to be the interventionist. And another one was a non-native man who had a business that was not doing so well. And so he was substitute teaching in science, and he taught the curriculum. And so we were able to do a test of interventionist, and we didn't find any significant differences in these outcomes of the students based upon the interventionist, which I thought said something about the curriculum. This is the final one, and this is not my study at all. This is the work of Dr. Phil May, Pat Cerna, Lamira De Bruin, it was in the American Journal of Public Health a number of years ago, and it's often cited as like the ideal study in a way for studying suicide prevention in Native communities. This was conducted at a time when the American Indian Life Skills was coming into fruition. And so I was asked if they could use the curriculum along with this comprehensive approach. And what they did in this approach is that they worked with natural helpers in the housing areas. They improved surveillance in terms of suicide and constant data and information gathering. They worked with screening and clinical interventions in outreach in conventional settings like the health clinic and the schools and social welfare programs, but they also in unconventional settings like by the lake, where there were clusters of cars, of community functions. And they also improved collaboration of community helpers with the tribal psychological service delivery personnel. So they did this really big public health approach. At the point at which they began this comprehensive intervention, you can see that there were approximately 40 incidents of suicide attempts. And then this is about 30 gestures in this community. It's a small community, all right. And then the number of completions, and you can see that with the attempts, definitely by the time they reported this out for the article, when they stopped collecting the data for this, to prepare for this article, that was a significant drop, and as well as with the gestures, and not so much with the actual deaths by suicide. But at least I do say, I mean, of course, we can't say that AILS was, the significant or contributing factor by any means. It was the comprehension of all this, and I think this is probably the best recommendations that we could give in terms of going forward for this kind of work. So in terms of this formal presentation, I just want to kind of leave you with some what I think are takeaways. One is that school-based suicide preventions have been shown to have positive outcomes across a wide array of settings in Native and non-Native communities. Many Native youth have benefited from these school-based suicide prevention interventions. We know that there are approaches for greater family involvement and community-wide change needs to occur, and has been happening much more in suicide prevention with American Indian and Alaska Natives, but they're fairly understudied. And then and what's exciting now is all the wonderful programs that are increasing the attention to the protective factors and the protective impact of cultural affiliation and cultural engagement in traditional practices against suicide. The way that we have tried to become more multi-level with American Indian life skills is through engagement with families by having, in some schools we've encouraged, and it's happened, where teachers do home visits on a monthly basis. There's this new thing, well, in recent years called the teacher advisory, and teachers who want to do this kind of work, it has to be voluntary on both parts, the teachers and the parents, have been make monthly home visits and just talk about whatever they want to talk about. And as it turned out, on the Blackfeet Reservation in Montana, there had been some suicides in the school, and that's really what the parents wanted to talk to the teachers about. So they felt that their training had prepared them for those kinds of conversations. In terms of more community-wide involvement, I've worked some with Head Start parents, the parent committees of Head Starts that really wanted to just go through the AILS curriculum themselves as a parent committee, those lessons that they thought they needed for their own benefit. Another way it's been used is in courses in tribal colleges where we're teaching resilience and using AILS as a case in point, and using the AILS manuals for case study. There's, also, I think we're working a lot more with boys and girls clubs, community agencies like that. So I think at this point, it's a time to turn it over for questions, if that's okay.
Fantastic. Well, thank you, Dr. LaFromboise, for that engaging presentation and for covering the very important effort that you have really dedicated your career to in terms of trying to engage and address this terrible problem of suicidality and people dying by suicide in our communities. And so I want to encourage members of the audience to go ahead and enter questions or comments in the Q&A function. Again, there should be a tab at the bottom of your Zoom screen. So please feel free to enter in anything you'd like me to refer to Professor LaFromboise for further discussion. Let me just start by conveying how important this effort has been for psychology and mental health in Indian country, which is to say that the AILS, your American Indian Life Skills Suicide Prevention Program, is one of the most widely known interventions that have been designed to address distress and disable dysfunction in Indian country. And in part because you've persisted with trying to refine and evaluate it for so many years. And in the different ways that you've worked on it, I know that there's been all kinds of challenges and hurdles and obstacles that you've encountered and had to figure out how to overcome just to persist in this effort to get good quality intervention research done. And I wonder if you could reflect a bit for us on, the challenges of intervention research, especially when you're trying to rigorously evaluate it for Native and Indigenous communities, and some of the things you've learned that you might like to impart to other investigators who are coming up through the ranks and wanting to figure out how to do efficient intervention research in a way that can matter for people at home.
Well, you're asking the hardest question. I think for me, one of the biggest challenges is trying to engage communities in further evaluating whatever interventions that they're doing. And with AILS, furthering evaluating AILS, as you can see, there's, most recently, I think a week ago or so, read an article that was reviewing again school-based suicide interventions and suicide prevention interventions, and they did talk about AILS. And of course, they have the charts and they go through, the quality of evaluations and high, medium, and low. And of course, at first you're sort of thrilled that at least it made it in this review, and then you start to look, and sometimes this is considered to be, kind of low-level evaluation, and because it's not large samples, it's not multiple schools, it's not multiple communities. And of course, I've tried that. I mean, I've tried to interest more than one community in order to have the sample size you would want that stands up to some of these larger studies. I mean, you'd have to have multiple reservations, and I can get, I've been able to get the cooperation of maybe one or two simultaneously, but then by the time I'm trying to get the others, the interest wanes on the two that had committed before, and it's just really difficult. And it's really sad because, I mean, people want the intervention, but they don't. And I realize the resistance to research, and why would you want to do another evaluation for something that's already out there? So and I guess I can say, well, because of its longevity, that says a lot about its effectiveness. But I remember when I began, and I was pre-tenured when Zuni asked me to do this. And of course, my academic advisors said, "Don't touch it. It's going to take you a long time. You might not get very many articles out of it, and it could be, really impede your ability to get tenure." I kept thinking to myself, well, but I'm being asked to do this, and I think I can beat the odds. I'm just going to do it anyway, and not talk about it very much among my colleagues, and then do the other work too, and hopefully I'll make it. So that's what that's my thinking, and I think that's the struggle that a lot of people coming out have. Fortunately, I know Stanford is getting better about this, and I think many other universities are. They realize that we need community-based services. We know that if Native faculty are going to be successful in academia, they're going to do that kind of work no matter what. And that's what they're called to do. And therefore, there ought to be some kind of accommodations for that and criteria for promotion and evaluation. So I think that, and also there are more community psychology oriented conventional APA approved programs. So, that's going on in the training, and hopefully there is a change, a real seismic change, so that people will do this work and will be very successful in doing this work. And I've just been very impressed with many of the people that you've had on this series who have done excellent work. And, at this stage in my life, kind of reflecting on what I've done, I just wonder, well, why couldn't I, I wish I could have done so much more. But I think what I try to do when people say, well, why are you still worried? Why are you still trying to evaluate this? It is because I think that we deserve the best. I mean, I think that Native communities deserve the best. They deserve it. And that it's amazing to me sometimes when I see the kinds of newly conceived or hardly evaluated curriculum opportunities that kind of get sold, or at least advertised, not even that, just solicited, trying to get people involved. And I do understand the enthusiasm at the beginning, but fortunately I'm glad that we didn't start with an idea and then go try to hawk it to different communities. And so I don't know if I'm answering your question. I'm trying to say that I really hope that people that are in doing this kind of work stay with it. And I hope that institutions, open up their criteria a little bit to recognize how time consuming it is and how important it is and how it really is, prevention science is a science. Okay.
Well, thanks for that. And just to follow up on one thing you mentioned, which I'd love to hear our audience and, hear a little more about your take on it, is the kind of aversiveness of many Native communities to research and researchers, and the challenge of figuring out how to connect and navigate and negotiate and enter into partnership, et cetera. But why are Native communities so suspicious of research in your experience?
Well, in my experience, I remember a little bit being on the other side, and that is that when I began teaching, I taught on the Turtle Mountain Reservation in Belcourt, North Dakota. And I married someone from there and lived there. And on Saturdays, the post office is open, Monday through Saturday, right? But on Saturdays, it's Saturday's a little bit more of a laid back day, and the post office closed at noon. And so basically people would be sort of rushing around 11 o'clock to pick up their mail right by the post office. And that was on the main street of the town, or I mean, of the center of the reservation. And up on the street was this car parked, and it was there every Saturday. And I said, who's that? What, there, that car's still there again. Oh, that's the anthropologist that's studying us. And I thought to myself, well, what a day to come and study this community, because it's so unlike day to day, Monday through Friday. I mean, what kind of impression is coming here as everybody's kind of colliding on the post office right at the last minute to pick up their mail? I don't know. I mean, that was just my thought. You know what I mean? But so I did have that sense of being observed and wondering what people were saying and what he was writing, and that kind of thing. Another is just a sense of taking something and taking information, even well-intentioned, and maybe sometimes not even understanding, the delicacy of the kinds of questions that are being asked. And, I think people were just really tired of that. And fortunately, this summer I had a wonderful experience with one of the students who had a summer summer fellowship to do research in her community. And so I tagged along, and I've never been in that experience because I've always been an outsider in the communities where I did the research. And I just saw the doors opening. Of course, she was, she's very much from there, lived there most of her life, very, part of the community. And people were happy to see that she was doing the work, and made all kinds of accommodations. And the youth knew her, and they trusted her, and they were willing to talk with her. And I mean, that's what we want. We want to be able to train people so that they can go into their own communities, and this just be a mutual part of data gathering, which has been done historically before non-natives came in and tried to do that, and making, and going forward and making things better.
Terrific. Thank you for that. Let's take a question here from one of the participants. Here's the question. Suicide/crisis interventions, such as involuntary or voluntary hospitalization, are deeply connected with the criminal justice system, and they can perpetuate more trauma, especially to marginalized individuals. Did any situations come up in your experience where crisis response was necessary, and how did you handle them to prevent further traumatization?
Thank you. That's a really good question. First of all, I want to say that one of the reasons that I also keep emphasizing school-based work is the fact that in our studies, and there are a couple more that I haven't mentioned here because I didn't want to belabor the point, but in one of the studies, we did ask the students how many, had they attempted suicide, and if so, would they let us know what they were thinking or feeling, or what had occurred at that time. And we had just 3 lines, open-ended. They could say whatever they wanted to say. And they really were very forthcoming in a lot of things that they said. But then we asked, did you go to the, did you go to the hospital? Or basically, did you go to the hospital? Because that was the only place that delivered any kind of suicide services for people who were suicidal. And 95% of them said no. And one of the reasons that we learned was the reason that they would say no is because if they did, then they could be put in as a protective measure, maybe into a jail that didn't have a bed. They didn't have a place for them at the hospital, or they would be whisked away to the state psychiatric hospital, which meant leaving the community. So that's why I feel that we can do a lot more by earlier identification. I think that I did. I mean, I don't, just for privacy's sake, wouldn't want to go through a lot. I can give you some examples. When I was doing a training of ALES, it was a 3-day training with Tribal Tech. One of the things that they do, which I think is a very, very important thing, is that when they offer a suicide prevention training, excuse me just a second, they also have professionals available in case anyone is triggered, or something happens during the training, which has happened before, which is that there's a death among by suicide among the client population of the people that we're training. And so people get calls and they get called out, and then that's hard for the service provider. And they did that. One time when I was training, I lost the training group. I mean, first of all, there had been a suicide, and actually it was grim. I was in the school building, and right outside the school was a carriage that was there, and it was ready for the funeral that was going to happen for the suicide that had happened just previously before I got there. And then there was another one. So that was day 1. And then day 2, we were just getting started, and everyone had to disperse because there was another death by suicide, which is traumatizing to everybody else. But I think the sad part, and we know that from some earlier studies, that if a community doesn't have a holding facility for a 72-hour hold, there have been times when they've taken, and if it's a young person, they've taken, it could even be a young person, and put them in the jail for observation, which is, again, a risk factor then for suicide or suicidal ideation, of being in, the trauma of being in jail. Another time I went up to a village in Canada with other people. There had been a cluster of suicides, and while we were there in a meeting with the Mounties, someone took off into the woods with a shotgun. And so, I mean, those are some of the stories. Those are some of the things. And I'd rather not think about those and think about the efforts to prevent it.
Yeah, right. And this is not ancient history. I know back at home in Montana, there's a reservation, probably more than one, where, people go to jail if they're suicidal or acting in a way that's self-injuring, just because there aren't resources to manage them medically in the way that would be more ideal. So thank you for that response. Here's another question that's come in. Thank you for sharing your passion, Dr. LaFromboise. I agree that Native communities deserve the best. The follow-up question is about assessment you've used during evaluation. Given that the commonly available psychometric tools are mostly developed based on general population and non-Indigenous populations, what are some approaches you've used to address the lack of Indigenous focused measures for understanding youth-child development?
Wow. Well, I think earlier on, it would be that we would create the study protocol and work with members of the community to go over the instruments and see what they thought, sort of needing, approval to some extent. Of course, I realize that they may, people may just think it's okay, you know what I mean, and go along with what the survey is. But I think it's, there's that part, okay, of just face validity and what do they think about the items. Increasingly more so, there's work done on some of these instruments, and we can look more at the psychometric characteristics, if they're reliable, and increasingly more people are doing factor analysis every time that they use a scale with the study population to see if the factor loadings hold up according to what has, been mentioned in the literature, or published in the literature. We just recently did some work with a scale in which we started to realize this business of reverse ordering, the magnitude of an item, which you do sort of as a check for truthfulness in the way people are responding, is also kind of a setup for diminishing the reliability of a scale. And so we, this idea of negatively worded items comes up. So, I mean, I think I guess what I'm saying is, I think it's important to have psychometric specialists in your camp, and to really do the kind of work on the scales that you're using or trying to use. And that's what the importance then of piloting with, people that are not going to be your subjects, and don't deplete the subject pool, but see if you can get that to do better with those scales. Another thing that we've done, though, that I really appreciate, is actually having focus groups and trying to create scales. And we've really learned so much from that. To be able to look at the language that people use and the concerns that they have and the ways that they talk about, say, depression. Todd Phelps did a wonderful senior honors thesis on how people in his community, determine depression as opposed to the symptom, the symptom focus that, the commonly used depression scales emphasize. And so, I mean, it's a whole, there's a whole field out there just needing more and more people that are sensitive to these issues.
Yeah, thank you for that. And you just mentioned the instance of depression. And it's interesting because I think in the biomedical, certainly in the clinical mental health world, suicide is often, sort of default formulated as the distal outcome of untreated clinical depression. And therefore, on that particular formulation, treating depression is what's key. But you're obviously taking a preventive approach. It's a school-based approach. It's with younger people. How does depression fit into your formulation with these age groups in that setting relative to suicide? And what does it mean if depression isn't really the primary point of intervention?
Well, I think first of all, I'm very interested in this work on the two-factor model of mental health. Okay, and so in the work that we're doing right now with the Tribal College study, we found that people could be high in depression and anxiety, but still high in psychological well-being on the RIF scale. Okay, so you kind of wonder, well, what does all this mean? But I also think it shows that you can, yes, that there is something to mood swings, and it doesn't have to necessarily be a diagnosis, not a diagnosis of depression. Like what is that really? There's so much to it. I think that the problem with all that is life is hard, and individuals don't live in a bubble, right? And so many of the problems, are problems that that are not controllable. And to have a sad or lingering or ruminating response to something horrible that has happened is probably pretty natural, right? And yes, the rates of depression are very high. All right. But also, and then that's in your area, Joe. And then we ask why. I mean, what? And it isn't always the individuals, and also it's just as well as just the. And I think this is sort of the trouble we have with sort of being trained from conventional psychology. Here I am showing you a logic model with coping, right? And advancing the idea of approach coping rather than avoidant coping. But sometimes, and in some cultures, when things are uncontrollable, avoidant coping might be a reasonable strategy to use. And so it's also so much. I think I remember whenever some people have criticized, well, the evaluation for the life skills didn't make any change in depression. It didn't. It changed ideation. It changed hopelessness. Okay, but depression is something that's also very difficult to change, right? And so I'm sort of reassured from this data from the Tribal College that you can, okay, yeah, I'm anxious at times, I'm depressed at times, but also I think I've had a meaningful life, and that's where the emphasis on spirituality really comes in, right? The more that we can advance reflection on why we're doing and what we're doing, and who's helping us do what we're doing, and how do we keep going, I think then we can sort of change our thinking away from the negativity.
Yeah, so maybe not intervention on depression symptoms per se, but the hopelessness is something that you did see change in a couple of those studies. What is it? How do you understand the link between the intervention in life skills and the changes in hopelessness?
I think it's about a future. Okay, hopelessness is thinking more forward thinking, not being hopeless. Hopelessness is hopefully we're trying to be more hopeful, right? But we are thinking about ourselves in a futuristic sense. It's sort of like the work on continuity, right? It goes beyond, right? And so, and this curriculum is all about, and that's why it's called life skills. This is not a cultural adapted version of Gil Botvin's life skills curriculum. This was named by the Zuni people. Actually, when we first went out there, we were foolish and we called it Zuni suicide prevention. And when you first handed it over to them, and they looked, they were appalled. Oh, you can't have that name. You can't have that word in the title. And that's not what this is about. This is about life. This is about celebrating life. And you see what I mean? It's so. How did I get to that? I guess I wanted to say it.
Yeah, no, it's very interesting to think about the cultural issues, and I'll ask you about that again in a minute, but let me turn to another question from a participant. I'm curious about how this would look in a younger population, say grades K through 6, as a preventative measure to suicidality. Can you speak on this? Have you done anything similar with this intervention with younger youth?
Thank you. That's great. That's a great question because it's asked a lot. I wish I could, but basically when people ask me about that, I look first of all, I would tell them and encourage them to look at the PATHS program, Positive Alternative Thinking Strategies. I think it was initially developed by Mark Greenberg, and it's highly, evidence-based. But what's interesting is that there has been a cultural adaptation of this curriculum done, working with, because what happens, people create these things and then communities see it and they say, oh, I like it, but it's not native enough. And then they start working on it, And so that's one I would recommend. The other is, though, we have now all this work in social emotional learning that is starting very young. Okay. And I think it's exciting, to help young children begin to identify their feelings and all that kind of thing. But I think that what is, I guess what I would wish is that we had some people who were interested in culturally adapting social emotional learning. Because what the emphasis in those programs a lot, I think, simply put, is empathy and conflict management, anger management and empathy. If you basically learning what other people think and then working it out with other people. And I have one of my former graduate students did work with children in war-torn countries. And she was asked, and she did then interview parents of these children that are in war-torn settings about, because she would notice the way they would play, and she wanted to know, well, what would be adaptive in this situation? Say there's a conflict on the playground or something. Well, what would you want your child to do? And many of the parents said, walk away, avoid it at all. They want to know, just get away. And what wouldn't it be neat to to find out from Native parents what empathy really is like, and how best to solve problems, and have those kinds of instructions be the basis, the content of social emotional development. So that let the schools, especially mainstream schools, that do the social emotional learning, and also, but why not be really cognizant of what the cultural teachings are about how best that we should do this when we're upset with somebody. Of course, I'm off on like biculturalism, but I do think that these things can be learned simultaneously.
Good point. Thank you. Let me pause for a minute to answer just a couple of questions that have come up that are more logistical. So people have asked, is this recording going to be available? Yes, all of the Indigenous Health and Wellbeing Colloquium seminars recordings are available both on the Department of Global Health and Social Medicine's seminar website, as well as the Harvard University Native American Programs website for this series. So this one will be added to that as well. Just give us a couple of weeks because we need to caption it just so that everyone can access it. It does take a little bit of time to get this up. So that will appear. The second question is, can we get copies of these slides? And so for that, I would refer you directly to Professor LaFromboise. You can Google Professor LaFromboise to get her email. It's LaFrom, L-A-F-R-O-M, @stanford.edu. I recommend that you inquire directly if Professor LaFromboise is eager to share these with you. On that, let's turn to another question here, because in the title of your talk, you have, the potential for schools as sacred spaces, and you referenced that a little bit. So one person asked, regarding the concept of schools as sacred places, what are your suggestions to help families overcome the trauma of boarding schools, which set out to disconnect Native people from their culture, where children were beaten and even killed? So maybe explain a little bit about the boarding schools to people who might not be so familiar with those, and then your ideas about how do we transform them from sites of horror to sacred places.
Well, I think one thing could be that we recognize, well, I think one thing is that boarding schools were horrible, right? But some schools were not horrific, all right? Although the idea of going away from your family for education is unfortunate, and that is a different issue than. But so there you have it. And let's say, because I've actually had parents, I've had I will say school board people, representatives tell me that in their community, some of the parents can't wait till their children age out of have to go to school, because they just don't want them there in any kind of school because of what they experienced in boarding school, which is really unfortunate. Okay. And so I think you have to recognize that there probably are some students in any school in a Native community that, I mean, it's probably a small percentage, but still may be their parents are either complacent or just really not wanting them to be indoctrinated into school. Okay. And that's why I think that then schools are better, even more and more challenged to be those special places, to be those sacred places where children are respected, where staff at all levels are respected, where people work towards getting along, where more of the, if at all possible, the cultural influences are brought into the school, because some students may not have the opportunity to learn about their culture just because their parents are not that culturally oriented and they're not able to transmit that. So I think we just realize that is, kind of like the ecological risk. It's, that is part of the ecological risk. That some of that is in the environment of resistance to formal education, but there's a lot that are not. And we can't undo the boarding school experience. I think the telling of it, though, is healing for the people that need, I think, and in the telling, maybe there'll be the telling that there was variability, in schools, and that some students had good experiences, or at least maybe they had better, maybe they had food, maybe they had regular meals. They had ability to be around more other people, learn from people from other tribes. I mean, you can try to also spin the positive side. I mean, it's hard to do right now in this time of testimonials and everything. But recognizing that that's out there, and that's part of the ecology of for educators to deal with. And it ought to be a challenge to say, I'm going to make this the best place possible so that people just love being here. They'd like to come to school. They like to come early. They'd like to stay late. There's all kind of activities going on. And for some communities, this is where the wedding receptions happen. This is where, powwows happen. This is where there's energy. There's energy in those schools. I mean, there can be energy if people make it. It's the opportunity. It's a place where people, in the case of suicide prevention, people trained and aware the risk factors and the signs and symptoms. They're they're right on the front lines, and if they know their students well and they care about their students, they're going to be able to detect when there are those shifts. Okay, and they also would know their students well enough to know if they have, really severe challenges that they're dealing with all the time before they get in that door. I mean, it's a point of entry, and it's also a place where, really, I mean, people, they are changed through new ideas and new opportunities and new outlooks. And that's the transcendent part of schools. That's why I think that they can be sacred spaces.
Well, thanks. I'm going to combine two questions here, which both have to do with tailoring to specific kinds of settings. So the first one is, hi, I work with Native students at our state school for the blind. Do you have any suggestions for how to implement some of the workbook and activities with students who have low or no vision? And then the second one is, what would you recommend for working with urban adolescents? That's coming out of Detroit. So a couple of thoughts about tailoring.
Those are really good questions. Okay. I have never worked with the blind population with ALS, but I think it could be done. I think that mainly because a lot of the richness of the curriculum are in the way in which the lesson is presented by the teacher, which they can hear, and the way in which the scenarios are written to be relevant to, I would say, very relevant to reservation life. We're in the middle school version that we're adding some more urban like situations in it, because that is one of the criticisms, that it seems to be more reservation oriented. But it's the power of the story, and the story can be about coping, and it can, and it can be about how a person is managing, feelings of aloneness and despondency and that kind of thing, if in case that it is. So I mean, and it would seem to me that even in the case of role plays, that people would get into it, orally. So that's my answer about the blind. The other one is about urban settings. The way the curriculum is developed, we also, we say at the very beginning that interventionists should, I mean, this is a kind of it's a platform for you to bring in the reality of your life, right? By the culture of the communities and more reservation settings, and urban living. I mean, urban living as well. I mean, and so what it is that, some of these problems supersede where you live, and you're putting on it the spin of how it plays itself out in the environment in which you live. We did use it in an urban setting in East Palo Alto a few years ago with 8th grade students, and the population there was predominantly Hispanic, some African American, Tongan, Samoan, people who have newly immigrated to the area. And we had postdocs that rewrote the scenarios, and they rewrote it for the relevance of East Palo Alto. And so it can be done that way as well. But what I usually see is that we have we have this curriculum, we give them, students are, they learn a lesson, they're given material that are kind of props, and then they role play it. And when they role play it, they bring in their own reality. So instead of whether or not to smoke pot in Detroit, it might have been that, my pusher wants me to sell heroin now. It's the level of what's going on. So whatever the issues are, that's my answer.
Thanks. Yeah, we just have time for one more brief question. So here it is. Do you have a sense to what extent American Indian youth access text lines and or call lines such as crisis text line or 988?
Well, I know that they certainly, I think they do. I don't know so much about 988, but what I do know that is, those that work with youth that are on social media, teachers and different people in the community. It's great. It's a great way to even identify people that are really struggling and are in crisis right now. So I would say, and I think it was Lisa Wexler that did an article on Native youth and their use of social media, and definitely I think it's an avenue for another outlet with which to get to students, Native students. Okay.
Yeah. Well, I can't thank you enough for coming and joining us and sharing your expertise. This is a career's worth of work that has just set the standard for how we might pioneer intervention research in Indian country. And so we're really grateful to have a chance to pick your brain and to hear the update, looking back on all this important contribution. So we're really grateful. If we were in the room and you could see everyone, we'd all clap our hands. I'm sure people are very enthusiastic. And we did have at the top of your presentation well over 100 people, and so we couldn't get all the questions and answers. But as I said, to go ahead and look up Professor LaFromboise's email. You can send questions to her privately following this. Now, by way of just closing out today, let me say that we do not at this point have a next Indigenous Health and Wellbeing Colloquium scheduled. We're in the process really of somewhat transitioning from pandemic influences where we did all these virtually to wanting to do more hybrid style. And so probably won't have one until next semester. Please stay tuned to look out for that. In terms of the regular seminar that I mentioned for the Department of Global Health and Social Medicine at Harvard Medical School, the next seminar will happen on November 1st at 2:30 p.m. It will be a hybrid seminar, so in person and Zoom, and it will feature the Johns Hopkins anthropologist Clara Hahn, speaking on where is the prison, household events, police, and the making of neighborhood conflict. So please feel free to join us for that. Finally, for the Harvard University Native American program, let me just issue a plug here for our big conference, which is next week, starting 1 week from today on that evening, Thursday evening. The conference is called Responsibility and Repair, Legacies of Indigenous Enslavement, Indenture, and Colonization at Harvard and Beyond. And the Harvard University Native American program, along with the Radcliffe Institute for Advanced Study, has been partnering for about a year to get this conference going. It's in response to the major report on the Harvard's legacy of slavery. And we are going to be speaking around these issues virtually as well as in person starting next Thursday evening and all day Friday. So please sign up and register to come to that virtually if you like. You can do the website by going to Radcliffe at Harvard to find the information. On that note, let me close this out and say thank you again to my department, Global Health and Social Medicine, and our staff who helped make this all work, and to the Harvard University Native American program, and especially again to you, Professor LaFromboise. Thanks again for joining us.
Thank you.
Have a great day, everyone. Bye-bye.